Good afternoon, everybody. I am Laura McGahey, Executive Director of Sláintecare, and I'm delighted to welcome you to our webinar this afternoon. Sláintecare is, as you know, about providing the right care in the right place at the right time. And this afternoon, our focus is on improving access to care. And you'll hear how 4 projects funded by the Sláintecare Integration Funds are having an impact on waiting times and waiting lists, and are working to improve the experience of people who use our health and social care services. The projects you'll hear from today are demonstrating some wonderful examples of innovation and change, which are resulting in people getting timely care as close to their homes as safely possible. I hope you find today's webinar both interesting and informative, and now I'm very pleased to hand you over to your facilitator, Dr. Gráinne Healy. Thank you very much.
Many thanks, Laura, and good afternoon. I'm Gráinne Healy, Chair of the Sláintecare Citizen and Staff Engagement, and I am delighted that you have joined us for today's webinar, the 9th Sláintecare Integration Fund webinar, part of our Learning Network event series. We are taking questions during the broadcast, so if asking a question or making a comment, please do indicate who the question is for, and we will make sure to get the answers for you. The Q&A button is at the bottom of your screen, and if you type in a question, it will come straight in here to me. We're very happy to be delivering these webinars in conjunction with the Health Service Executive and with the support of IFIC, the International Forum for Integrated Care. Sláintecare is, as Laura has reminded us, about providing right care in the right place at the right time by the right team. And in these webinars, you'll hear how the projects funded by the Sláintecare Integration Funds and some HSE funded work is showing us best practice for healthcare reform and displaying how many have adapted work practices and created improved pathways while responding to COVID-19. This afternoon, as Laura mentioned, our focus is on improving access to care. We're featuring presentations from 4 Sláintecare funded initiatives, which are providing care in ways that are reducing waiting lists by creating alternative pathways for patients. These projects are contributing to hospital avoidance, reducing waiting lists, and improving the experience of people who use our health and social care services. Some initiatives are about moving care closer to home for patients by delivering care in the local community. Others are providing interventions which mean that patients don't need to travel to acute facilities for care, while others still are rolling out good practice models used elsewhere, which have been proven to reduce waits and enhance patient outcomes and experiences. These initiatives are also leading to a drop in hospital attendances, thus freeing up appointments at hospitals for those in acute need, while ensuring that all patients get the care they require. All of these approaches have clear positive outcomes for patients and for services, and all are helping to deliver models of care as envisioned in both the Sláintecare 10-year plan and the recently published HSE Corporate Plan 2021-2024 and the forthcoming Sláintecare Action Plan 21-24. Aiming to build a responsive and multi-pathway route to care for patients, bringing care closer to home for many by locating it in the community, and thus better meeting patients' needs by the right team in a timely, efficient, and effective manner. So we have 4 projects doing innovative and effective change work, leading to alternative pathways for patients and service users to showcase for you today. As Sláintecare continues on a journey to ensure the right care, right time, right place, these projects allow us to demonstrate to you what Sláintecare alternative pathways look like on the ground. Our first project for you this afternoon is from the Galway Cardiology Diagnostics, a great example of how care can be delivered to patients with cardio problems, linking to community and hospital specialist care. Let's hear from that new service now. So I'm delighted to be joined this afternoon by the Chief Cardiac Physiologist, Mr. Paul Nolan, and Paul is working with Galway University Hospital's Community Cardiac Diagnostics project. Paul, you're very welcome this afternoon.
Thanks very much.
Paul, can I ask you to start by telling us a little bit about what is the project about?
Well, I suppose in essence, it's delivering cardiac diagnostics in the community in 5 satellite centres, protected for primary care physicians. So we know from surveys from the Irish College of General Practitioners that GPs only have direct access to Holter monitoring or long-term heart monitoring in less than 20% of patients. And that can be an important test in working somebody up who's had a stroke to see if they've had an irregular heart rhythm called atrial fibrillation, that they may need to be started on a blood thinner. And also importantly, less than 15% of them have direct access to echocardiography, the heart ultrasound. And that's a hugely important test in a number of clinical settings like blackouts or syncope. It's the key diagnostic test in heart failure. And there's 90,000 patients in Ireland with heart failure. There's 10,000 new diagnoses every year. And there's estimated to be about 16 or 160,000 patients with impending heart failure or structural abnormalities that will lead to heart failure. So it's a key test. And, you know, many of the guidelines, say the National Institute of Clinical Excellence, would suggest that a patient with suspected heart failure should have an echo done within 6 weeks. So if you're a GP and you want to get an echo, your route is really through normal traditional outpatients, or to refer somebody acutely to the ED or an AMU. So it was to provide GPs with an alternative pathway to access cardiac diagnostics for their patients.
Right. And of course, not every GP can have these high-tech equipments in every surgery in the country. So your solution is to bring this type of technology and expertise out into the community, away from the acutes, in 5 areas, I understand. What are you actually bringing? Is it a machine with a person like yourself who knows how to read it? What exactly are you delivering?
So I suppose I'm presenting on behalf of our team of far more glamorous but shyer cardiac physiologists. So we rotate out from GUH into community settings in Claremorris, Tuam, Gort, and we have 2 centres in Galway City. And what it means is it means it's away from the hospital environment, which has been which patients have welcomed for a number of reasons, particularly around COVID. People were scared to come to hospital, were quite happy to go to a primary care centre. And even just simple things like parking for patients. You know, it's a small building, so it's not a big long walk from outpatients up to our department. So that's the aim, and that's what we're delivering to patients. So yeah, we bring all the equipment out with us. We pack up a big suitcase, and one of the accredited physiologists who has specific training around cardiac ultrasound performing and reporting them, they bring their expertise out. We report everything in the centre that we're doing the scans, and then importantly, all those scans and reports come back into the hospital and are uploaded into our cardiovascular IT system and also onto the electronic chart. So if the patient represents, everything is there, the images and the report. So we integrate it, so they're integrated into the hospital system.
Right, and that integration, of course, is so important, both for patients, but also for those who may be providing further medical interventions or support. They have the information, they know what the reading was when you took it in the community, and if they present again, they've got something to compare it to. So the GPs obviously then are happier that they're getting to refer people through a pathway. What impact on waiting times is that having for the patients?
Yeah, so I suppose the important thing for us is if you look at our hospital outpatient service in terms of, you know, so we do have access to urgent slots within the hospital service. There's a lot of pressure on those. So from oncology, from our own cardiology service. So the median waiting time, so the most common waiting time for an echo in the hospital for an outpatient is about 25 weeks.
Okay.
For the patients that have currently gone through, and we'll probably do our 500th patient, if not in April, very early in May.
500.
Got up and running fully in January. So 93% of patients 93% of echoes are done in less than 6 weeks. and 87% of all investigations are done in less than 6 weeks. So it's an extremely timely service. About 35% of our echoes are done in a week or less. So the GPs are getting quick access, and it's a very easy referral pathway. Health links were great, so we got the referral pathway is set up through health links, which really streamlines as it comes directly into our department, and we can respond back to GPs to say, yeah, we're going to book your patient in. Or on the rare occasion, we might say, you may not realize your patient had this test done 3 months ago, and that will be communicated back to them through health mail to say, we don't think this patient needs a repeat investigation, and that seems to be working well with the GPs. It's very few that we're turning down.
It's a much faster turnaround, both for the GP in terms of the service he or she may be providing, but also for the patient. I mean, gosh, 25 down to 6 weeks is like the amount of stress and worry over a 25-week period, and to be able to get those kinds of results in 6 weeks. I mean, what kind of response are you getting from the patients?
So the patients are usually thrilled with it. So a lot of comments were like, everything went superbly, couldn't fault it. So we've been surveying our patients through a phone questionnaire. So all of them are, there's 100% of them are satisfied or very satisfied, with an average score of 4.9 out of 5. And that's a questionnaire that's based on a British Society of Echocardiography questionnaire to measure patients' experience of cardiac diagnostic services. So they've been very, very appreciative of it. One patient actually commented that when we were querying them, they said they were very dissatisfied with the waiting time. And I was surprised by that. And we sort of went, well, why were you dissatisfied? She goes, well, what I mean is, I was originally referred to the hospital over a year ago, and I hadn't been called, and my GP re-referred me to this. So this waiting time is great, but the previous one was horrendous.
So she wasn't even talking about your service at all.
The patient saying, I can't believe how quickly I got the appointment, fantastic service. Another patient was surprised how called they were quick and commented on how easy it was to park. We got a card off a patient just, arrived. I did a clinic in Gort, arrived out the following week to a clinic in Gort, and there was a card there saying, thank you very much. And even like the GP, we surveyed GPs about their satisfaction, which is being mixed, and I might discuss that because there's been some learning first on that. But one of the referrals came in with a line on saying, community diagnostic service, a fantastic service, keep it going type of thing. So, which is really good.
Yeah. So talk a little bit about the GP challenges that you're saying it's not.
So I suppose for us, what we communicate with the GPs about the service through a number of ways. We communicated via health mail. We communicated via health links message. We've done a number of CME meetings for GPs in the evenings, and the feedback has been very good. And we asked a couple of questions of GPs through a survey, like how long they're practicing and stuff like that around the baseline stuff. And this reflected questions that were in the ICGP survey about access to diagnostics. And what we learned quickly was 100% of them are satisfied with the referral process through health links. And 100% of them were delighted with the waiting time, or satisfied or very satisfied. But some were very dissatisfied, some were satisfied, some were very satisfied. So the lowest scores were for our communication and our report turnaround times. And I think that what we lost in the message was how GPs were going to be notified about the results and the expected time frame. So we were saying 10 working days, but one of the GPs came back and said, if I'm dealing with a heart failure patient, 10 days is too long. I need a 3-day turnaround. So we're gonna look at that. And I think one of the challenges for us was that our admin person hasn't been fully appointed. One of the secretaries in the office, Rachel, has taken on the role on top of her other work. She's doing a fantastic job doing it. It's been brilliant. But you can only stretch the band so far. And I think that might be one of our learnings from it. Really
maybe a dedicated role for a person so that you can bring it down to a 3-day turnaround. Well done. And finally, Paul, maybe you just comment on COVID and the COVID impacts on the project. Have you had to pivot? Have you had to change what you're doing or delay it? Or how has it impacted on the work?
So I think there's two things I'd like to say about that. One is that COVID obviously impacted on the start of the project. So it delayed us starting, and when they were unpaused, one of the challenges, cardiac physiologists can be difficult to recruit. So we had somebody lined up, but they then had to give a period of notice. So we really got our first clinic running in November. We got more clinics on board in December. And one of the impacts of COVID was the space that we were getting in primary care centres because of changes to work practices to cope with COVID. The rooms that were available maybe twice a week were under significant pressure. So that was one of the things. But as I said, already alluded to, I think one of the advantages is that moving it out of the hospital service for patients who were worried about attending hospital and would ring up and say, you know, I don't want to come to hospital for that test yet, but they'd be quite happy to come to their local primary care centre or a smaller building to have that test done. Great. And despite, you know, I was worried about whether we'd reach our outcomes and outputs in terms of COVID and whether that would impact it, particularly if there was a significant second wave, which there was. But actually, we managed to keep our service going through all of January, February, into March and April, and it's sort of, the key is now getting it fully embedded. I don't call it a project, I call it a service, because it's not to my mind, it's not going anywhere.
It's not going anywhere.
It needs to continue to be funded. And despite the challenges of COVID, I think we've hit the outcomes that we wanted to achieve.
Well done, Paul. It's a great service, and well done to you and the team on the delivery of it. And long may it continue. Thank you very much for joining us today, Paul.
Thanks a million for the opportunity, and obviously thanks for the funding as well to allow us to bring it to fruition.
So thank you to Paul, Nolan and the team there in Galway, and lovely to see the cards and the comments from the service users and just their appreciation of the work that's being done, delivering this successful service that Paul and the team are very determined to see sustained into the future. And we've gotten a number of questions on that presentation, which we'll bring to you in the panel session later on this afternoon. Our second project this afternoon is an initiative in North Dublin, which is tackling sexual health matters. I met two of that team earlier this week to hear about how they're providing screening and supports to tackle sexually transmitted infections in a community setting. You're very welcome. I'm delighted to be joined this afternoon by the North Dublin Integrated Sexually Transmitted Infections Services. I have with me Dr. Jack Lambert, who is a consultant in infectious diseases and genitourinary medicine in the Mater Hospital in Dublin, and also a clinical nursing specialist with the project, Paul Duggan. Jack, you're very welcome. Thanks so much for taking the time this afternoon. Can I come to you first and just ask you to tell us a little bit about, you know, the background to the project, where it came from, if you would.
Right. Well, I came to Ireland 15 years ago and took the responsibility of setting up a sexual health service at the Mater Hospital. And one of the clear messages was there was a big disconnect between the hospital and the community. So the classic GUM services is people come to the hospital. The services throughout the country is you queue up for an appointment, you call for an appointment, the waiting lists are long. You know, there's a huge disconnect. And one of the things I learned really quickly was that a lot of the GPs were providing sexual health services, but they needed more support and communication and training. So early on, I ran a STI service at the Mater Hospital, not an optimal service from a patient standpoint. I started training a lot of the GPs in North Dublin. But clearly, the population in North Dublin is a disadvantaged population. We've had challenges over the years. There's not been good communication. There's not been a good seamless service between the hospital and the community, especially a lot of the disenfranchised populations that the Mater Hospital, takes full ownership of and interest in managing, but it's a huge challenging managing this population. So Sláintecare was really an opportunity to put together a service that could be patient-friendly, that GPs could easily refer patients in, that patients didn't have to go to the hospital, could go to actually some of the community services that were supported by the Mater Hospital SDI services. So that was really the opportunity of Sláintecare to put together the plan that we've always had of kind of integrating services between the hospital and the community, because many SDI services should be community-based with support from the hospital and the consultants, not hospital consultant-led. So that this has been kind of a long-term dream that we've been, able to initiate, at the Mater as part of the Sláintecare project.
Great stuff. So we'll come now to Paul Duggan, the clinical nursing specialist. And Paul, I suppose what we're interested in is what's different now for the patient, for the person coming to the services, now that they're no longer having to go to the hospital? What does it look like and feel like for them?
So with it, we aim to have a much more relaxed atmosphere and environment within the community. I think a lot of people have associations and connotations with hospital services, and they may associate it with, illness, with death of a loved one, things like that. So taking something as essential as a sexual health service and moving that into a more relaxed environment, it's a golden opportunity for the service users and for ourselves. So like that, one of the silver linings of COVID has been the movement away from walk-in services, the move towards scheduled appointments. And that has allowed, it has led while people are working from home, things like that, or while people are working shift work, they're able to schedule in a set time to take that, 20-minute chunk out of their day, come to ourselves, have their checkup and go on their way. And the return then for results or treatment as needed is as straightforward a process as can be.
Great. So talk to me a little bit. I mean, I saw from some of the background data I was reading, there has been no fall off in STIs during COVID. In fact, so I guess, if you're seeing an upsurge in STIs, have you seen an increase in the number of people demanding the service?
Yes, the demand for service is, higher than ever. There's been a lot of restrictions on all of the services nationally in response to COVID. But like that, it's the recovery process, and it's how we recover from this, almost a full year of restricted access. With sexually transmitted infections, a lot of them are asymptomatic in that a person can have them and not know that they have this infection. And it's only by, your routine testing and treatment that you can break the chain of infection. So the getting back on track and getting the asymptomatic or routine services back up and running it's a key part of our recovery process. And until we have full capacity again at all services, it's a very uphill battle.
Okay. And tell me a little bit about, moving the service out of the hospital into the community. What kind of impacts are you seeing on waiting lists? What kind of outcomes are you having?
So historically, the waiting times in the Mater Hospital were about 4 to 6 weeks for an STI appointment, and that may have been asymptomatic or symptomatic services. So since the introduction of the community-based service, we've managed to change the asymptomatic waiting times down to between 5 and 7 days of initial contact. And that has allowed the movement of those services into the community setting has freed up more capacity for complex cases within the hospital environment. And that has reduced that time down to, on average, between a week to 2 weeks. So dramatic improvement, but we're continuing to scale up the level of complexity that we can manage in the community setting as well. And that will have, hopefully, further impact on waiting times.
So that is a dramatic impact on those waiting times. And of course, as we know, with any of these issues, early intervention, early the better, it's less complicated, it's easier to treat. And I suppose then what you're seeing is that in the hospital, you're saving those acute spaces for the people who really need that kind of acute intervention or acute care. So well done that it's having those kinds of early results. And of course, downstream, That means the saving of money for the service also. So you're really ticking a lot of the boxes here. Can you talk a little bit, Paul, about the challenges of moving from a hospital setting to a community setting? What are the hurdles that you have to get over?
So my background before coming to this role was within a community setting. So I did have I had the ideas, the understanding of how it should be. There are barriers when it comes to anything new. Change can take a long time, and particularly change during the world being turned upside down. So some of the barriers initially was just something as simple as redirecting traffic, letting people know, this appointment will no longer be in the hospital setting, it'll be out in the community, and you would still have the odd 1 or 2 person that may arrive to the wrong clinic. Beyond that, then there's just some of the logistics, like the treatments. Medication is easily given in the community setting, but an intramuscular injection still required a hospital visit as such. So that's something that we're working on at the moment, and trying to make more medication available within the community setting as well. And that has just meant staff training, our anaphylaxis training, the upskilling of our response if there was anything that did go wrong.
Other projects that we're talking to who have been shifting care into the community, they've talked about things like, computer systems speaking to each other, ordering systems, things that actually, when they're not connected or they're not speaking to each other, they can be problematic. Have you had some of those logistic issues as well?
We have. So one of the issues initially was the labeling of samples. We weren't able to access label printers in the community setting. So it was handwriting each of the samples. And although it doesn't seem too much, it was an extra couple of minutes at the end of every consultation that, throughout the course of, say, a 10-person session, you could have added in 2 more patients had you not had to handwrite each of the samples. Right. So we now have access. We've now linked up that system, and we are able to print the labels in our community site. But that is something that had only kind of become available when we relocated our premise due to Echo Street rather than the initial sites, because we were able to piggyback on the Matter network in some of the other premises.
Okay, so being in Eccles Street is a distinct advantage then, even in terms of being located so close to the Matter itself. So tell me, Paul, finally, maybe around the kind of numbers that you're seeing and the issues around sustainability.
So our average week is 3 new patient sessions and then 1 return patient session. This is just while we're kind of rescaling services after the most recent COVID surge, with aims to over the coming weeks, hopefully move towards a 5-day service. But our current throughput of patients is around 40 to 45 patients per week. And then that includes any return visits or treatment that those 40 to 45 people may need. So realistically, you could end up seeing, say, 60 to 65 people in the week if 20 of those people have an infection that, wasn't picked up at the initial visit or was an asymptomatic infection.
Okay. So to sustain this project, what do you think you need?
In order to sustain the project, I think, we just need continued, dedication and support to the cause. I think we need more awareness around STIs and more awareness around how easy it is to access the service. Beyond that, then staffing, scaling up of staff is always the ideal scenario. But at the moment, it's, I think attentions are elsewhere with the recovery process from COVID. So I think in a couple of months' time, we may be in a much different position where that is something that's more feasible.
Great. Okay, so Paul Duggan and Dr. Jack Lambert, thank you so much, and best of luck with your North Dublin integrated STI service. Thank you very much for joining us this afternoon. So thanks to Jack Lambert and Paul Duggan there, and I look forward to talking to both of them in our panel discussion later in the webinar. Moving then from Dublin to southeast of the country, our third project, Fast Track Knee Pathway, is about delivering faster access for orthopedics, in particular, developing a more efficient and effective pathway to care for those with knee issues, which can be so debilitating if left untreated due to a long wait for care and attention. Here's what the team told us when I spoke with them earlier this week. So I'm very pleased to be joined this afternoon by two members of the team who are working on a very interesting initiative in University Hospital Waterford. I have a clinical specialist physiotherapy, Siobhan Corcoran, and also Dr. Terence Murphy, the consultant orthopedic surgeon, again, with University Hospital in Waterford. Can we start perhaps, Siobhan, with you telling us a little bit about what is Fast Track Knee Pathway all about?
So the Fast Track Knee Pathway, really the aim behind this is to better streamline the referral pathway for patients into orthopedics, particularly for patients with arthritis of their knees who need intervention. Unfortunately, the waiting lists around the country for orthopedics are very long, and in Waterford you can wait up to 4 years for an appointment to see an orthopedic surgeon if your referral is deemed as routine, which can often be tricky depending on what information is on the referral itself. Now, from our own data, we know that the majority of patients who come to us with knee problems actually don't need orthopedic intervention. A lot of them can have their care provided locally at primary care level. So with this in mind, we set up the Fast Track Knee Pathway, where patients would have more timely access to physiotherapy at community level, and also access to a dietetic service, which was previously unavailable to this particular cohort of patients. And for most people, that was where they would have their care and would satisfy most of what they need in terms of their own criteria for their knee problem. But if patients then were identified as needing intervention, we could give them rapid access to a clinic here in University Hospital Waterford. So the net result is that patients with the most urgent needs are being seen much more quickly for their intervention, whilst the people who can be managed more at local level are having their care provided closer to home.
I suppose the background to that is, with this pathway in particular and this clinical syndrome as such with knee osteoarthritis, a lot of initial treatment is not hospital based, and our keen approach was to try and move it outside the hospital system so they're seeing the right person at the right time in the right situation. And so looking at international data, especially Canada, where a lot of these projects had been running traditionally, that these patients need a lot of multidisciplinary approach initially regarding physiotherapy, strengthening programs, and even a psychological aspect which is built into the program on top of dietetics, looking at weight management, are key components of the management of these patients before they need to see a surgeon and go down the route of surgical intervention or even any injection-based intervention. So some people feel, you know, are we wasting time and slowing these patients and getting to us? But this is a key component of the patient's management, even when they go the operative route, because that can affect their outcome ultimately. And so to get those patients into the right streams from the get-go, as opposed to coming onto a big list of orthopedic surgeons where you have hundreds of knee referrals and they just sit there with nothing happening, at least then we can progress through it and get them into the correct pathway as quick as we can. And that's very good to it. So.
Yeah, and I saw somewhere that some 56% of people who might be on those lists actually ultimately don't require a surgeon's service. So is this part of you're making sure people get to the correct maybe physio treatment in the community, and then you just end up focusing on the people who really need that surgical intervention and getting to them faster, I presume.
That's the whole aim, exactly. So by getting a very structured physio program in often a class-based scenario, which actually works even better for the patients, they're working their way through this, and people who can't progress then are the ones who need further intervention, be it to see us through the fast track pathway and maybe get an injection to get them over the hump, or if they're failing that, then get them onto a surgical pathway much quicker than previously we could have achieved.
Very good. So what kind of planned outcomes did you have at the beginning, and what are you seeing? What kind of results are you seeing now?
So the main aim really was to improve access to primary care physiotherapy, because we feel really this is the cornerstone of the whole pathway being a success. So we've invested most of our money and our time into really improving the access for physiotherapy in the community. So we've managed to reduce physiotherapy wait times for up to 1/3 across our pilot sites. So in Enniscorthy in particular, we've managed to reach our goal of a 4-month wait time for physiotherapy. So for a person who attends Enniscorthy and has their course of physiotherapy, if they're deemed then as requiring orthopaedic intervention, we can get them into the rapid access clinic in Waterford within a 4-week period. So ultimately for a patient in Enniscorthy who presents to physiotherapy with a knee problem, they can see Mr. Murphy in the orthopaedic department here within 6 to 8 months, having had all their core physiotherapy and dietetic treatments, which is up to 5 times quicker than the current model of care.
Well, that's very impressive. I was looking at data showing some people on a 4-year wait list, whereas you're talking about maybe 4 to 6 months. That's a great improvement. And I suppose the other thing is it takes the pressure off the hospital in terms of, you know, spaces that you have, the appointments that you'll have available, because many of these people are now actually being diverted to a more appropriate pathway in the community.
Exactly. It goes back to seeing the correct person at the correct time in their disease pathway as such. So yeah, we're trying to reduce the footfall within a hospital environment and get the community to engage and begin the initial management of these patients in a structured manner to try and optimize that. And so I often see it. I see people who X-ray wise look like they may require intervention, but they're nowhere near completed their physiotherapy program, or have had any conservative management, and I end up seeing them 2 to 3 times further in my clinic as a result. And so if we can reduce that down to I'm seeing them only maybe on them once off or twice, then you're developing a much more efficient pathway.
Very good. And I know one of the things that you have been focusing on is around ensuring that GPs get to know about the pathway that you are providing. Will you talk a little bit about why GPs and why you put a focus on communicating with them?
Okay. So I suppose the referral will always initiate with the GP, and before we sort of set up the pathway, we had a focus group with some GPs here in Waterford just to find out a little bit around their decision making for referrals. And I suppose for GPs, there's a source of frustration that they know their patients are going to be waiting a long time. And they admit that they often maybe do refer people in sooner than they know they need surgery, but it's in anticipation that they will be waiting 4 years. And that was one of the big, I suppose, feedback we had from the GP. The other point from GPs was that they know how long primary care physiotherapy waiting times are. So we were in a situation where they were maybe just forgoing physiotherapy referrals and sending straight to orthopedics or sending to both systems services at the same time. And then what was happening is the whole system was just getting clogged up, you know, at every corner. So that's why we really felt that we needed to engage with GPs to let them know what we were doing. Our traditional model of that would have been to have some education nights and some, you know, maybe get-togethers in their surgeries, but COVID obviously changed all that. So we had to look at more innovative ways of getting to GPs. They're so busy right now with the vaccine rollout that although they appreciate what we're doing, you know, their time is very limited. So with that in mind, we try to look at some alternative ways of engaging with them. I would have put together some Twitter videos of our results and infographic videos about our service so that some GPs would use that as a way of keeping up to date with what's going on in our health service, and that was well received. We also send quarterly newsletters to the GP practices and the pilot sites to let them know about the current waiting times and progressions. So it was just about, I suppose, putting a slightly different take on things when you were communicating with them about our project results.
Very good, very good. And I know also that we're going to hear from some patient testimonies in a moment, but what I'd like to do is just finish off maybe by asking you about replicability and sustainability. Is it replicable, and what do you need to sustain this?
I think we started off as a pilot site, as our own initiative, tried to look at a way of reducing patient frustration, waiting time, GP frustration. And so we've set up, based on international standards, a kind of a specific physiotherapy program that these patients work through, which is entirely replicable in other sites. It's not specific to Waterford patients, it's completely international. So from that aspect it is. Then from a pathway perspective, we feel it is very replicable across the whole country, assuming we have buy-in from all the key stakeholders. And I suppose that's the key part, both from a community base to the hospital base, there has to be stakeholder buy-in. And if that is brought on, there's no reason why it can't be rolled out across the country as a national program.
That's great. Thank you both for joining us this afternoon, and keep up the great work on what I think is a really innovative and successful program. Thank you both very much.
Thank you.
Thanks, Brian.
Hello, my name is Wayne Russell, and I'd just like to talk to you about my follow-up from dealings with my knees at UHW. I started off just over 17 stone. Now I'm just under 14. And without Deirdre's help and guidance in the right foods to eat and the support, listening to me moan and groan, you know, she was a huge, huge difference in my quality of life that I feel now. Then again, unexpected phone call from Louise, the physio, over Zoom. In the post came out a booklet, bands, and Louise showed me exercises to do. I've been following those exercises. Are my knees better? Yes. I'm lighter. Are the exercises helping? Yes. Because I know in myself that if I don't do the exercises down the line, I'll be suffering even further. The dealings between Louise and Deirdre have made a huge difference to my quality of life. So without their help and support, I wouldn't feel the way I feel today. So thank you.
So impressive results for those suffering with knee ailments, and particularly impressive to be making inroads into waiting lists, giving patients like Wayne there faster access to supports around diet, exercise, and all that is required to keep the knees healthy. So very, very interesting project. The fourth project this afternoon that I have for you is from Tala University Hospital Urology Department, and they're using an advanced nurse practitioner to bring care to the community by telephone, also by delivering in a community clinic setting. I met and spoke with 3 members of the team, and here they are to tell us about this new service, which is reducing wait times and ensuring patients are getting care faster, enhancing the patient outcomes and improving their experiences. I'm really delighted to welcome to the webinar this afternoon some of the team who are operating a very interesting project in Tala. The title, it's a long title, Provision of an Advanced Nurse Practitioner for the Development of an Integrated Referral Pathway for Male Lower Urinary Tract Symptoms and the Development of a Secondary Care Nurse-Led Urology Clinic for Benign Urological Symptoms. So I'm going to go to you first, Lynn, if that's okay. You're all very welcome, and maybe get you to talk to us about the project. What's the background to it, and your role as an advanced nurse practitioner?
Hi, Grania. So, Grania, I joined the team here in Tala last August as candidate AMP for the development of this male lower urinary tract symptom clinic. And I suppose just a quick explanation of what lower urinary tract symptoms, or Lutz as we know them as, it's an umbrella term really for clinical symptoms in relation to your urinary system. So things like urinary frequency, up a lot at night, or maybe incontinence. So quite, troublesome, impactful symptoms on your quality of life. In Ireland, unfortunately, the waiting list for urology services is quite large. In 2019, there was just under 31,000 patients waiting to see urologists. Yeah. And this was estimated to increase to just under 47,000 by 2022. And I'm sure with the impact COVID has since had, that is going to be a lot higher. Unfortunately, our urology waiting list in Tala is actually the highest waiting list nationally. So what tends to happen is benign conditions such as men suffering lower urinary tract symptoms, unfortunately tend to go to kind of the end of the triage pile, if you like. So we have lots of men in the community really suffering that intervention can really improve and change their quality of life. So that's kind of the background to the clinic.
Okay.
So as you're aware, we started in the midst of COVID. So really our main aims at the beginning was to tackle a waiting list. We had quite a number of patients who are waiting for return appointments, as well as a number of patients waiting for new appointments as well. So we developed a telephone list system with an agreed referral and performa format. And we got that up and running probably early last September. To date then, I've reviewed just under 600 patients in the first 6 months of the clinic. So a lot of them, 420 was actually patients who are waiting for a return appointment. And just clinics didn't have the capacity to see them back. And I've reviewed just under 180 new patients as well. With this, I've managed to discharge approximately 65. And a lot of this is just healthcare advice, lifestyle modification, as well as some pharmacological intervention also. I identified about 4% of this cohort that actually probably would have ended up in an accident and emergency referral or visit. So I caught them and we got them referred back into the acute system in a more timely manner.
Very good, very good.
Excuse me. So yeah, so we've
Lynn,
got it up and running. So that was really our first. Sorry.
Just is the clinic in the hospital or does it operate in the community? Just tell me how it works.
So for the first few months, it was all telephone clinic, me working from the hospital and all telephone review. In the last few weeks, we've actually managed to get a community clinic up and running out in Tala. And that's great. And that's patients that through our telephone clinic, I've identified as needing further intervention or investigation, and I can see them in the clinic. So it's definitely, in line with the, right time, right care, right place. So we're seeing them closer to home. Mm-hmm. And, patients are nervous about coming into the hospital at the moment. So they're much more comfortable coming to this community clinic.
Yeah.
So obviously going forward, we'll hope to expand that further in the future.
And tell me, what are the patients saying about the service they're getting? How are they, are they getting to see people, getting to see you sooner? And I suppose I was taken by your point about, the sooner many of these men can get an early intervention, their lives must really just improve dramatically when they get early intervention. What are they saying?
Absolutely. They're delighted with the clinic. And actually, to my own surprise, they're delighted with the telephone review clinic. Often I'm discussing with men quite intimate symptoms. It can be very embarrassing. Irish men don't like to talk about their intimate symptoms. And more, quite a lot of them have said, once you outlined exactly our discussion for the telephone, they were really comfortable in their own homes. They could be private and, feel really at ease and found it much easier to speak to me, actually. Yeah.
That's interesting. No, not the face-to-face embarrassment that they might have had otherwise.
Exactly. And then by the time they meet me, we've built a rapport on the telephone. So actually, the embarrassment has gone.
Right.
They're
very good. Very good. So Angela, can I come to you, Angela Clayton-Lee, and your role really is around kind of managing these projects, making sure that they're working. Mm-hmm. Talk a little bit maybe about the COVID-19 challenges that this project would have faced in trying to get this service up and running.
Yeah, so obviously COVID presented us with a lot of challenges in TUH as it did to every other side around the country. One of the main challenges would have been we were very aware of the backlog of patients who really desperately needed to engage and be given access to this service. So in one way, we were lucky because Lynn was able to identify quite a large cohort who could be handled, you know, quite sufficiently by telephone. So that in itself was a huge help. But we also were very conscious of trying to find a secure location to enable face-to-face contact to take place. Throughout our OPD, as in other OPDs, we've been trying to minimize face-to-face appointments here. And our urology department is by nature extremely busy here in Tallaght. So this was a new clinic, and you know, we were very conscious of not inadvertently overloading the department with additional face-to-face appointments. So we tracked it very carefully, and Lynn worked through as many as possible with the telephone clinics. And then in the background, I suppose, I was trying to find a location, which we did, and that's been up and running in March. And we're also actively working with Naas General Hospital. We're hoping that once their outpatient department opens up a little bit, they have an area that would be very suitable for Lynn to use as well. So we're working with Naas to expand it into Naas, but absolutely the weekly clinic is giving our patients definite improved access. Other than that, they wouldn't have got in to see a urologist here or any of our other nursing support staff. So without this project and with Lynn's considerable expertise that she brought to the project, genuinely, as Lynn referred to at the beginning, those patients' triage referrals would still be literally waiting there and waiting and would not have been seen and having their symptoms resolved. So it has been challenging, but we were fortunate that we were able to combine the telephone and then move towards the face-to-face as the project advanced. And that's really where we are now. And that's what we hope to do going forward, is just continue ultimately with the face-to-face clinics.
Very good. And can I come to you again and ask you a little bit about some of the project outcomes, you know, the numbers of people you've seen, and in particular, maybe the difference in wait times that your intervention is making to patients?
Yeah. So to date, Grania, as I've said, I've seen or I've reviewed just under 600 patients, and both in the new group and in the patients who are waiting a return appointment, those patients had dated back as far as 2014. So yeah, wow. Unfortunately. So we have cleared a lot of 2014, 15, 16, and even in the new patients now, I'm currently on approximately 2019. So we've managed to clear quite a number of backlog to date.
Wow, that's great. So the backlog being cleared, people who've been on waiting lists for a long time, and then into the future, I suppose the idea is to try. Do you have a target for what you would like to be able to see people from the time they get referred to you seeing them? What would your ideal target be?
Ideally, going into the future when our backlog is cleared, that's when we can really go about introducing the integrated care pathway with the GPs. And actually, the aim would be to keep a lot of these patients in primary care, that the GPs would have access to myself for advice or education, and that we'll actually decrease the amount of these patients being referred to the acute services in the first place.
Brilliant. So again, right care, right place, right time.
Yeah,
that's
absolutely.
Super, Lynn. Thank you. So we're being joined now by Dr. Rowan Casey, and Dr. Casey is the consultant urologist with the Tallaght University Hospital. Dr. Casey, you're very welcome. Can I ask you to just, as a clinician, what are the clinical impacts you're seeing now that the project has been up and running?
Well, I think it's been amazing. I mean, speaking to Lynn Casey, she's a very experienced nurse with 20 years urology experience. So she's brought a level of experience that's been amazing. And that covers the depth and breadth of urology. So she isn't just focused on that one area. She brings a wealth of knowledge and experience and patient-facing experience, which is good. So we've seen, number one, a very good feedback from patients in terms of their satisfaction with the service. She's addressed a large number of patients on our waiting list who we haven't been able to see face-to-face as we planned. And she's been able to see them remotely and deal with them over the phone and save them trips to hospitals and patients are obviously worried about COVID. So that's obviously been reassuring to them that they've been able to be seen virtually by phone or video. And I think then we can see the impact on our service. We're starting to clear that waiting list of patients. And what we're seeing now is an improvement in the amount of new patients we're able to see in the acute setting and deal with their problems. So I think we've seen a very good, on a number of fronts, very good results with the service so far, and we're very pleased with it.
Very good. And in terms of the future of it, the expansion of it, I mean, I know from speaking with both your colleagues, Lynn was telling us, you know, that Tala University Hospital has one of the largest urology practices, waiting lists. So actually having this initiative in Tala is very significant nationally for these waiting lists. Would that be true to say?
Yes, absolutely. So we do have a huge referral base from around the country. And so I think it's been absolutely essential that we could try and manage patients as close to home as possible. So both over telephone and video. And then Lynn also feeds into the community to provide care closer to patients' homes. So that's the first thing I'd say that's been remarkable. The second thing she's going to do is embed this kind of practice through a kind of a protocol-driven system where she works off a specific kind of algorithm or flow chart. And she's going to try and embed that with the local GP community so that we can actually defer some of the referrals in the first place so that they can be managed through their GPs more efficiently, and only really come to see us at the point where they may need further intervention or investigation or surgery. Right. So I think that's been very important.
So effectively the patient gets to have the treatment from their GP, distant from having to travel to hospitals, COVID times or otherwise. And then it's when they get to a point where they really need your intervention, you're seeing them faster, sooner. Yeah. Okay, excellent.
Absolutely. So I think what we're trying to do is set up a kind of an integrated shared care model with our local GP colleagues, where Lynn will embed some training with the GPs and the nurses. She'll be available for queries and concerns about patients, and that more of the care will be delivered locally in the early stages, and they will see us as they need to, if they need further investigation or hospital care.
Okay, so it's fewer visits and then kind of accelerating in for those who need maybe more acute or specific care.
Yes,
Dr. Casey, can I thank you and your colleagues for spending time with us this afternoon, and wish you the very best of luck with the project as you continue to develop and deliver it. Thank you all.
Thanks very much for your help.
Thank you. So thank you there to Dr. Owen Casey and the whole urology team setting up that integrated care model in liaising with the GPs. So you've heard about the work of the 4 integrated fund projects, and I have a great panel of people for you this afternoon from the projects that you've just heard about. We also seem to have a very active set of participant viewers logged on this afternoon. I've got lots of extra questions that have come in over the last hour or so. So without further ado, let me introduce the panel to you. I have Paul Nolan from the Galway Cardiology Diagnostics, whom you met a little while earlier. I also have Paul Duggan and Dr. Jack Lambert, again from the North Dublin STI Services. Siobhan Corcoran and Mr. Terence Murphy from the Fast Track Knee Pathway Initiative, and Lynn Casey, the Advanced Nurse Practitioner from the Tala University Hospital Urology Project. So a good group here with us this afternoon. And, you know, in going back perhaps to maybe to some of the earlier presentations that we heard about. Paul, I might come to you first, if that's okay. And I'm just going to put a couple of questions that have come in from the participants. Niamh Talon wonders how many sessions are being run and how many people can be seen per session. And she also wants to know, are there extra staffing or other costs involved in running the service?
Yeah, so we run 4 to 5 sessions a week, 4 to 5 clinics a week. So they're full days. So we see 8 to 9 patients. And under the integration funding, we got funding for a senior cardiac physiologist, and we got funding for machines. So the first year costs were 147,000, and the second year cost when we get the funding for the second year, obviously that's going to happen, will be 90,000. So it's averaging out about €90 per investigation and €75 for the second year. So it's very cost effective compared to outsourcing that elsewhere.
And Verona Walsh wanted to know, the cardiac equipment that you're taking out to the primary care centres, was that sourced especially for this initiative, or was it equipment that you already had in the hospital? Good question, that.
Yeah, so it was sourced, but it was equipment we were familiar with in the hospital, and also all that equipment can integrate into our cardiovascular IT and our electronic health record, so that the investigations and reports of stuff that was done in the community are available in the hospital system if the patient represents or has to be referred in. And I think that's vitally important. So the images and the tracings can be seen if needed.
Right, and that's, of course, so important. And finally, Paul, you mentioned hitting project outcomes in your presentation. Would you just talk a little bit more about those for us, please?
Well, I think ultimately we're delivering what we set out to do. So we're delivering those clinics in 5 centres, satellite centres. We've got the wait times less than 6 weeks, as we discussed in our chat. I think what's good to see is that 26% of the referrals are redirects from OPD. What we looked at as well is to see, are we keeping those people out? And so only 13% were re-referred within 30 days, either to outpatients or to an acute area like ED or MEU. And even if they were referred, the referrals are actually appropriate. Either we suggested they should be referred because of an abnormal finding, or they were represented because of, they developed an irregular heart rhythm, for example, that wasn't present when we saw them. But even then, because the results are on the system, that smoothed their pathway through the AMU, for example. They didn't have to have that test repeated. I should say, of course, maybe I didn't emphasize enough in the chat we had, the support of our consultants here is vitally important. Like they've given us space to lead it, but some of these tests fall into grey areas where you need their input, and they're always available. We've really good support from them, and we value that hugely. But I think one of the things that struck me is that the hard metrics are very easy, but I think sometimes there's the softer stuff we don't capture. So I did a clinic in Gort, and I saw an 83-year-old lady who was referred in for a heart ultrasound. Her husband was stopped from driving because of a syncopal episode, a blackout episode, and she doesn't drive. So if she'd been referred to the hospital, it would have been a 90-kilometre round trip, €110 of a taxi fare. Right. But for her, it was a 5-minute trip down the road, and she even forgot her little book of numbers, important phone numbers. So I was able to drop that into her on the way home. So I think you don't capture that maybe in hard metrics, but I think it's equally important, I think.
Yeah, that's a great testimony. And my God, what an expensive taxi ride for an 83-year-old woman. So look, well done. That's great. Moving on then to back to Paul Duggan and Jack Lambert. I don't know if Jack is with us. His camera's not on. Oh, he is there. Great. Can I come to you first, Dr. Lambert? Others, when they're developing community-based services, speak about the importance of partnerships for success. Can you tell us a little bit about the partnerships you've had to make to enable the service to work in a community-based setting?
Yeah, well, originally we'd planned on having our service in some of the HSE community clinics. Because of COVID, we had to relocate to HIV Ireland. And this really became an opportunity because the original plan was just to partner with the North Dublin GPs. And this opportunity, we then moved into the same building as a community-based organization that was doing similar services. So we kind of needed them and they needed us. We also worked with Safety Net. We worked with the social inclusion. We were able to kind of decompress the emergency room at the Mater Hospital to take patients, patients who didn't have a GP were showing up to the emergency room for PrEP, SDI services. So I would say that, that COVID, SDIs didn't go down in COVID. We changed our remit of Sláintecare out of necessity, and it became an opportunity to be able to be in the same building and work closer with these community organizations, because I think, this is really the model moving forward, kind of
forced on us by COVID. And we've actually, like I said, we've actually surpassed our numbers despite, COVID, because of the referrals we've developed by this partnership.
Very good. And before I go into the numbers, maybe I'll go to your colleague Paul Duggan there. Paul, a question came in from one of the participants who's watching, and they're wondering about is there a drop-in or an in-person services available for those under 18? Might be outside of your area, Paul, but do you deal, for example, with under 18-year-olds, or where do they go for this kind of support?
So at the moment, we would deal with service users kind of 16, 17 years of age. Okay. It again comes down to age of consent and issues there. But there is a dedicated young persons clinic in St. James's Hospital. There is also the opportunity of referring them to the ID service in the Mater Hospital. If there was a case that it was more relevant to come to ourselves than, say, St. James's location-wise or things like that, it would be through the main hospital service, just as it would be at consultant's discretion rather than a nurse-based decision.
Okay, great. Catherine Healy asked that question and I wanted to put it to you before I forget. Let's go on then, Paul, maybe and have a look at, I know you've done an analysis of your service users, and I know, we're talking about almost 1,000 users when we spoke during the week. Tell us a little bit about what you know about them. What's your analysis of your 1,000 users telling us?
So the analysis of the first 1,000 users has shown us that there's 1 in 4 pickup rate of infection. What you would normally expect to see would be maybe, say, 1 in 5. Even then, it sometimes that little bit lower depending on times of the year. So it is an increase, but again, it's people that may not have been aware they had an infection. They just came in for routine testing, and without providing that service, you won't have picked up that infection. And it's so easy, every time someone has a contact, there's a chance of passing on the infection, and that person then may not know they need to be tested or treated. It's only really the person that develops symptoms that may be fully aware of the importance of getting checked. So it's about the education and the encouragement for everyone to get tested and the ease of access to testing services.
Yeah, I mean, that really is a challenge, isn't it? The high rates of unknown infection, people who don't have symptoms, they're not having pain. So the idea of regular checking is just so important, and education is key to that, isn't it?
Yes. So we try to kind of advertise ourselves like the dentist, where you go at least once a year, whether you think you need it or not.
Great.
But
yeah.
Beyond that, then it's just depending on the type of relationship the person is in, their level of sexual activity, whether they need to test more frequently, if it's appropriate to test that little bit less frequently. But again, it comes down to education and letting a person know what's right for them, because our sexual health is so unique to an individual. Rather than being, a one-size-fits-all.
Sure. And Georgina Kilcoyne was obviously listening and heard you talk about having to fill in the labels by hand. And she was asking, what are the logistic challenges in relation to dealing with samples that need to be brought back to the hospital or the lab when you're working out in the community?
So with it, that was actually one of the hidden costs of the project initially, in that we would have had to pay, in the primary care centres, we would have been paying for a courier to deliver each of our samples to the lab, either back to the hospital lab for inputting and then out to UCD for processing, or directly to UCD for processing, depending on the type of sample. But now that we're within the remit of the campus as such, it is just a case of, taking turns to drop over to the hospital lab to drop off the samples. But like that, we're saving, say, €8 every day, just not having the courier there.
Every penny counts, as the fella says in the ad. That's great. Thanks, Paul. Just to move on then, we have also Siobhan Corcoran and Mr. Terence Murphy from the Fast Track Knee Pathway initiative. And thanks for joining us for the panel this afternoon. Mr. Murphy, how many patients have been taken from the waiting list because of the Fast Track service?
So I suppose over the last year or so, we've just under 300 patients have come directly off that waiting list and through this pathway, and have completed their physio program and as a result, most of these are discharged. Like we had from our video earlier, where these patients are much more informed, much more educated. Out of that, we had approximately 8 patients who then were referred on to the Rapid Access Clinic, which runs alongside my clinic with Siobhan. And so of those, they were all seen within 4 weeks of referrals. So it has reduced the numbers, and it's given them a dedicated pathway that works.
Okay. Eileen, Brett asks the question, having listened to your presentation, where are the patients seen by the physio? Eileen wants to know.
So these are all based in the community physio centres, is what we're really pushing towards. So it's to keep them out of the main hospital physio departments, keep them in their community settings. So the initial initiative was based here in Waterford, and we were trying to set up Dungarvan. Then we have now progressed on to Wexford, was our second site to be involved, where they are being seen in the community physio departments in Wexford. And now we're moving on towards Kilkenny and hopefully South Tipperary, which is all part of our catchment area, which is quite large. So it's not something we could just roll out across the region. We had to start and progress, but it's all community based is what we're trying to achieve.
And the physios are in the community is the point.
Yeah.
Yeah. Now we had a couple of questions in on that. Siobhan, can I come to you? And just, I know embracing IT has been, key to the success of the project. Tell us a little bit about the challenges that you had there and what you had to overcome.
I suppose that, as with every other project, COVID-19, I suppose, put a lot of challenges in the way of our original model of care. Traditionally, we would have been offering in-person knee class programs throughout primary care, which was very productive in terms of getting through waiting list numbers and giving people, I suppose, a really nice model of treatment. So with COVID, that obviously all came to a halt, and we managed to transition both our musculoskeletal triage service here within UHW and our primary care physiotherapy services into a full telehealth program. So wasn't quite, I suppose, able to achieve the same numbers, but we still managed to keep up a very good service and make good inroads on waiting list by using a telehealth service. Another little initiative that we had as part of the project is the development of an automated database for use in primary care physiotherapy. So as most primary care physios are familiar with, is I suppose not a huge amount of administrative support, and a lot of the time in our days is used for administrative reasons, which is not really the best use of our skills. So with this automated database, the physio can generate appointment letters, discharge letters, statistics, all at the click of a button. And this has really helped to increase their direct time with patient care, which has been even more important because we haven't been able to offer class-based programs. So that is something that hopefully we can, expand on when we roll out the program regionally. Finally, I suppose engaging with GPs and getting GPs on board with our program was a massive factor in making it a success. Traditionally, as we said in our interview, this would have been through meetings and CME nights, but GPs have just been so busy, and we had to look at more innovative ways. So we've really gotten into making little infographic videos and infographics that we can put on Twitter and email. And I think it just gives a bit more of a succinct overview of the project, and then GPs can come back to us with individual queries. So that may be something that even when COVID is finished, we probably will continue with.
Very good. And I must say, if you want to go on and look at those on YouTube, they're very impressive little videos, and really give an insight into, the way the project works, what the pathway looks like, and some of the numbers that you've managed to successfully take off wait lists and get faster treatment too. So well worth people following those up. I want to come to Lynn. I haven't forgotten about you, Lynn. And there are some questions also coming in from listeners and viewers. Stephanie Cleary wants to know, what was the percentage of patients discharged from the Lutz project? There was a slide that went up, but maybe we didn't leave it up long enough.
Okay, so it's slightly different for the return patients and the new patients. I think the return patients we had as high as 65%.
Okay.
And a lot of that was just spending, good quality time on the phone with them, giving them quite a long consultation and going through all the lifestyle modifications.
Yeah.
And we have a criteria in the telephone performa that we developed about who we can discharge safely. So they would have been discharged with a letter going back to their GP with, of course, the premise that if their symptoms deteriorate in the future, they can be referred directly back into the service.
Right, yeah. So 65% is what she suspected, but I think she was surprised by it. So well done. And one that's just come in here to me now, what triage tool is used to determine severity and management of the Lutz symptoms? This is a very technical question. Obviously, Eamon Rogers is an anorak in these matters. So
Okay.
What's the response to that?
So the kind of gold standard is a questionnaire, and it's called the IPSS. It's the International Prostate Symptom Score. And it's a number of questions, as well as a quality of life score that covers different types of lower urinary tract symptoms. For example, how many times do you get up at night to pass water? How many times in a day, different symptoms. And then you score the system, and you can categorize the patients into mild, moderate, or severe symptoms, or severe, symptoms. That's how we categorize, and it will be from that, that we would.
So that's an international best practice standard model that you use there. There's also a question about, you've really made inroads into big, long, like 2014 is a hell of a long time, isn't it, to be on a waiting list? So when the large backlog of patients waiting for this service is addressed, what are the next steps then for the project, Lynn?
Okay, so the aim is to get on top of our long waiting return patients and have them all seen within an appropriate or the prescribed period of time. And then the main aim would be for our new patients to really have sustainable wait times of 3 months or less. So that's our goal. But also even further than that, for patients being referred for, say, the more severe category, we're going to develop a KPI of a shorter period of time, because really they're the patients who will most likely end up in the emergency room. And of course, that's what we want to avoid. We want to get them treated before that ever has to happen.
Yeah.
As well as that, then, as alluded to in our recording, we really want to get ourselves more visible in the community. So one option is we're hoping to develop another community clinic down in Naas General Hospital. And within our catchment, quite a cohort of patients are from down in the Naas Kildare area. So that will be really taking the care closer to home for that cohort of patients.
Very good. Great. So thanks very much for that, Lynn. Paul, just come back to you for a moment, and I might get a quick comment from each of you. The support that Sláintecare has been able to provide is all really about providing people with ideas and energy to do the good work. Looking to the future, you said earlier on, you need this project, the support to continue. Is it just money, or is there something else that would be really useful to help you continue, sustain, and maybe mainstream what you're doing all over the country?
So I'm not sure which Paul it was, but
yeah, yourself first, Paul Nolan. Sorry, I'll come to you in a minute.
Oh, you're okay. I think keeping the person in post is vitally important, because we have the equipment bought. So having that person in post, and obviously if we drop that, then trying to recruit for cardiac physiologists can be quite difficult. And access to space in the community has been difficult. And I think that's reflective more of the fact that primary care centres have had to change how they work to, maintain social distancing within COVID. But hopefully, with the vaccination programme, and as restrictions become lessened and there's less requirement to socially distance within healthcare facilities, then maybe that space will become more available. So I think getting access to primary care centres that's in appropriate locations is the main thing to sustain it going forward, along with maintaining our staffing workforce. I'd like to see it expanded, so we we have a side funding project in through another funding mechanism that may allow us to actually expand it and have 5 fully satellite centres out away from Galway City, and then have a fixed community-based centre within Galway City itself, and move more people out, maybe take people directly off the waiting list, as well as the direct GP referrals.
Very good. So you have a world domination plan. Well done, Paul.
Not the world, just Galway and Mayo. And
just Galway, Mayo for now. Thanks very much. Paul, coming to you, Paul Duggan. Again, for you, the Sláintecare funds have helped you do what you've done, but is there something else that you really need to keep this sustainable and maybe expand?
Sustainability wise, again, it's just keeping us all in our jobs, keeping us in place. But beyond that, then something like an automated appointment system, online bookings would make life so much easier and would make it, so much more accessible, and allow, admin tasks, admin to kind of change their role, focus on other areas beyond the constant bookings. But other than that, just scalability wise, my dream is advanced nurse practitioner. My end goal, but the staffing, having additional staff in the service would be fantastic. Just allow us to, double, triple, quadruple our numbers.
Very good. Thanks very much, Paul. And over to Siobhan and Mr. Murphy there. I mean, I'm thinking, maybe this automated service that you've devised to save all your admin time, you might share that with Paul Duggan, and it might be a huge help to them in saving them admin time, because it certainly seems to be working for you guys. So again, the same question to you. Sustainability, Sláintecare funding has been great, but looking to the future, sustainability and growth of the really innovative service that you're providing. What do you need? Either of you can answer this, Siobhan or
I suppose space is always a big issue, and getting dedicated space where these programs can run out of, and then likewise having that space and availability for the rapid access clinic is becoming more challenging, especially in COVID times with social distancing and our limitations on numbers of patients in departments, but hopefully that will improve. And then from an expansion point of view, again, it's staffing, and that's the key component here. Education of staff and staff buy-in to provide the service is key.
Yeah, absolutely.
Just my own experience, the work of a primary care physio has changed a lot in recent years, and that our demographic is getting older. We're going to have a lot of demands on the service with frailty and long COVID. So things like chronic musculoskeletal conditions like knee osteoarthritis, although very important, are slipping down the list of priority in primary care. So I think having a dedicated post like we're providing for this project, and expanding dedicated posts that are not being moved off to cover other areas that are obviously very important as well. I think that's really important for us to focus on that, because the knock-on effects on the wider acute system down here is really affected if we don't have the dedicated service of primary care.
Right. So keeping that dedicated staff on that work is really also what protects the kind of the seep out into the rest of the system. If they can keep doing that work, then that work gets done. Great. Lynn, coming to you, same question. What do you need? What's the future? I know you've plans to move out into NACE, etc. But what do you think?
That is the big plan for the future. So currently I'm probably, the majority of my time is in the acute service. I'd like to flip that and have the majority of my time being in the community service. And, big education drive with the GPs and practice nurses on how to deal with the patients, through an integrated care pathway, shared care between us, that I will be accessible for education or advice. And really, as the education piece falls into place, that I would nearly act like a gatekeeper for referrals. So really to make sure it is only really the people who need acute services go in, and we don't get back into building our waiting lists again. Yeah. The other thing I'd just like to say as a slight aside is this project, is going to have a huge impact on many men.
Yeah.
And really, it could be repeated a lot all around Ireland in all of the major hospitals. Whilst, you know, our urology weakness might be the worst, urology nationally with their weakness are dreadful. So, I mean, this project is so replicable, you know, it could really have a huge impact in urology nationally.
Yeah. And I thought, you know, your story about men, and not to be stereotyping, but that idea of, you know, I have 4 brothers, you know, and my father before them. And I tell you, they would not talk about anything to do with, you know, personal bodily matters. You could forget it. So there is something about that mix that you were using, like the telephone call, where you can lay it out and talk about things. And then if you have to see them, you already have the relationship. I thought that was a lovely, and you found that that's worked.
Oh, absolutely. And had you have asked me prior, I would have said, no, you know, men are rubbish on the phone. But actually, they really embraced it, and they had a sense of comfort, or I suppose security, sitting in their own home. So it's worked out really well, and it's had a great impact on when I do see them as well.
Yeah, no, great work. Listen, many thanks to all of you. Great work that you're doing. Wonderful that you could come on and share it with so many of the other people who, like yourselves, are doing this change work in the system, in the service. And, you know, it does take time to prepare videos. You do have to put clinics on hold, or, you know, put other work aside. So we really do appreciate you giving us the time to come on and to share. And then this afternoon to be willing to take questions. And you never know what's going to come in on the feed. So I hope that was okay for you. So thank you to each of our guests today, to Laura McGahey for her message of support at the start of the webinar. Well done, as I say, to everyone doing this great Sláintecare project work, and it is continuing. Today's emphasis on access to care, I think, is certainly a message of hope. And I think it really concretizes what Sláintecare is delivering, and shows how the many innovative ways of working are making our health and care services better for all. So thank you to the whole team here who helped produce the session, to Rosaline Harlan, Muriel Farrell, Lindsay Dre, Ingrid Doyle, Erica Kinsella, Suzanne Lynch, and Tom Dukes. You can watch this webinar back or recommend it to your colleagues. It will be available on the Sláintecare website, so do send us your feedback. The questions we didn't get a chance to answer in the webinar will be posted in the coming days for you. So from me, Gráinne Healy, stay safe, wash your hands and hold firm. We'll see you next time. Thank you all very, very much.